Good afternoon, everyone. Thank you for staying with us. So, I'm a rheumatologist from Auckland, New Zealand. I work in a private practice with over 1,000 EDS patients, and I do have a long waiting list. Sorry about that. And I'm currently New Zealand's only sub-specialised rheumatologist for Ehlers-Danlos syndrome. Conflict of interest is I am on the International Steering Committee for the next HEDS criteria. However, I don't think that has any impact on this particular talk. So this talk outline is going to first talk about some of the basics of neurology and tissue response to injury as the background to how prolotherapy is then going to make a difference when people have suffered injuries that don't heal normally. So first and foremost, the pain receptors, there are multiple pain receptors in the skin. These include fast-firing myelinated tissue receptors, also known as A-delta receptors, that are both mechanical, thermosensitive, i.e. temperature, and chemical receptors. And then there are these slow-firing C-fiber, which are unmyelinated nerves, that also feed into the tissue in the skin, but they also feed into the deep tissue. There are chemical and temperature receptors that are slow firing in the skin as well, but not in the deep tissue. So the deep tissue only has slow firing unmyelinated stretch receptors, which is why if someone has a full thickness burn, they don't actually feel it, it doesn't hurt. They only feel the partial thickness areas. These slow-firing stretch receptors give pain when there's stretch on tissue. Boils are a good example, as are torn muscles, partially torn, not fully torn, but partially torn muscles, tendons, ligaments, bone fractures because there is actually fascia that wraps around the bone. When you've got constipation, colic, or artery compressions, things like gallstones, or bleeds inside the brain. There are also chemicals that can stimulate these slow-firing receptors, and in particular, acidic chemicals are well noted to affect this, which is how some people get reflux pain. But a complete rupture of a tendon is painless. I don't know if many of you people saw Popeye many years ago, Popeye the Sailor Man, and he's bulged his muscles up and they came out like this. Well, if someone has a rupture of the long head of biceps, they look exactly like Popeye. So pain can be broken into somatic pain, which is physical pain, and psychosomatic pain. And then you've got the superficial pain and the deep pain. So the superficial or peripheral pain arises in the skin and also sometimes from lactic acid in muscles, from that acid area. And in general, this pain has an initial response followed by a later response when you get pain occur. And these signals are transmitted by different pathways. And for those of you who want to delve into these pathways, the next paragraph there shows you, but I sometimes struggle to pronounce these words, so I'm going to let you read that. Then the deep pain arises from the joint receptors. So again, these are stretch receptors, tendons and fascia. And the quality of the deep pain can be dull, aching, or even burning. The burning part comes from some of that acid effect. Deep pain is accompanied by a definite autonomic response with sweating, nausea. These are adrenaline responses. Those of you with POTS know these symptoms very well. And you get changes in blood pressure and the heart rate. The heart rate goes up. And again, the last sentence there shows you the pathways that it follows. So when we react to pain, we get a sudden, unexpected damage to the skin, followed by 3 responses. The first is we're startled. What's going on? And in that response, we flex, we have a readjustment to our posture, and we'll look to see where's this coming from. We get the autonomic response with release of adrenaline, noradrenaline, also known as norepinephrine and epinephrine. cortisol and ACTH, which stimulates cortisol production. And we get a vasoconstriction, so if you're bleeding, you don't want to bleed out. It tries to contract down at the site of the injury. And piloerection, which is the little hairs on your skin stand up, but it's actually a response to deeper actions within the body. And then we get a behavioral response. We go, ouch, that hurts. Some people use other words. We might rub the sore area. And we have other learned responses, but when babies have pain, they cry. That's not actually a learned response. That's their unlearned response to pain. Central sensitization. This corresponds to an enhancement in the functional status of neurons and so on and so on. Let's put this into plain terms. When you stimulate a nerve and the stimulation keeps going, that nerve can ramp up in its stimulation process. The effect of that is you get more sensitive to stimuli, so a less painful stimulus can make you hurt, and then what would normally be non-painful stimulus hurts. And the area of hurt can spread beyond the area of the injury. And so the central sensitization occurs when you've got a prolonged injury response or process. The increased pain can affect our response to other non-noxious stimuli and even simple, very innocuous stimuli. Now, what's the tissue response to injury? Tissue heals slowly. Not quickly, slowly. Subacute pain is pain that lasts 6 weeks to 3 months. And chronic pain is pain persisting for more than 3 months. And while I've got one study there are actually dozens of studies that quote this. Those who have never suffered chronic pain frequently say the pain is all in your head. They are wrong. Let me repeat that. They are wrong. And just because someone hasn't experienced chronic pain, that doesn't remove the ignorance. So while we have central sensitization that can make pain feel worse, if the focus for pain goes, the central sensitization goes too. The extreme form of central sensitization, of course, is complex regional pain syndrome, or shortened to CRIPS. And this can, on occasion, not always, but sometimes when you treat the underlying source, can go too. We have demonstrated that in our clinic, but I haven't been able to demonstrate it on everybody. So some of my patients with CRIPS still have CRIPS, and I know I can't help them. But we help them the best we can with what we can do. Now, I'm just going to give a little word of warning. If any of you are squeamish with slides of injury, the next slide is a graphic. It's the only one, and I'll let you know when it's over. But for the next 30 seconds, anyone squeamish, just close your eyes. This is the healing of a full thickness burn, chemical burn, over a 6-month period in someone without EDS. And you may see on day 1, which was actually about 15 minutes after the injury, that the area of full thickness is grey. On day 3, you've got the inflammation present. By week 7, the inflammation is settling down and there's healing at the cutaneous tissues and it's coming together. And by 3 months, it's mostly healed and there's very little change between 3 months and 6 months. But it shows you the healing isn't instant. Prolotherapy healing is the same. I've moved on for those who want to open their eyes now. So, the problem we have is when wounds don't heal properly, when scar tissue doesn't heal properly, and this is where prolotherapy can help make a difference. Prolotherapy means proliferation of scar tissue, also known as sclerotherapy for the laying down of scar tissue. Scar tissue, when it happens, it realigns to the stresses in the tissue, tightens up the damaged tissue, which brings wounds together. If someone cuts your tummy open, you've got exactly the same healing process happening. This can be more impaired in someone with Col3A1 or Col5A1, but for most, it recreates the damaged ligaments and tendons and brings them back to what they were prior to injury. As Tina noted in her talk, when you're forming tissue, you're getting abnormal scar tissue forming. And she showed lovely slides showing that, beautifully demonstrated. You can add more tissue. If you think it's easy to break a single stick like a matchstick, but hard to break a bundle of sticks, just put more sticks in the bundle and it's hard to break. And that's what prolotherapy is doing. And this is well demonstrated in this picture by Augustus Atkinson in 1803, where he said it's easy to break individual sticks, but hard to break a bundle of sticks. And he was talking about Napoleon and how Napoleon couldn't beat the British because the British had banded together. Likewise, it's easy to break a few strands of collagen, but hard to break a bundle of collagen, even abnormal collagen. And if we can put more strands in that bundle, even thin abnormal strands, and bring the bundle back to what it was prior to injury, then the stretch that's on the tissue and on those stretch fibers, those C fibers within the tissue, is eased, and in theory, the pain goes. In practice, it usually goes, not always. So prolotherapy has been well established as agents that lay down fibrous tissue. In varicose veins, they've been used for 6 or 7 decades or more to make the body lay down fibrous tissue within a vein to cause that vein to tighten up and turn into scar tissue. It's been used for more than 60 years in soft tissue. And the work of George Hackett, an American orthopaedic surgeon, really spearheaded this pre-1960, and we have 2 of his books signed by him in our office. Use of dextrose is widespread, but not as strong. It still has effect. And we now use polydocal and tetradecal, but others will use platelet-rich plasma, which appears to be as effective. So prolotherapy initiates the body's wound-healing cascade of inflammation, just the same as if your tummy was cut open in surgery. And we have multiple studies showing this. So, there have been many studies in the last 20 years about the efficacy of the stronger agents that we use in soft tissue, including the knee, the elbow, the forces, which are the back of the throat, tighten those up to stop snoring, the rotator cuff around the shoulder, TMJ, etc. And while we gave up on dextrose in 2006, which was being used as a backup for those with allergies to the stronger agents, it still has some efficacy. And we've got studies comparing platelet-rich plasma to dextrose, which show favor for PRP, but both still have effect. Remember, people with EDS tissue have tissue that's more easily damaged with injury. EDS doesn't cause injury, accidents cause injury, but when you have EDS, you're more easily injured from a more minor accident. And it takes around an average of 3 injections to stop a joint that dislocates multiple times from dislocating, which we'll show shortly. In our practice, we've seen that when we brought tissues back to the original strength, then there's no longer pain. And studies show major sustained results at 12 months with PRP. And again, we assume the abnormal stretch on the deep C fibers, what we mentioned earlier, those firing with stretch on tissue. As you get more tissue there, there's less stretch across the whole lot. And so there's less pain receptors going on until there's no pain at all. And we have seen that pain goes in more than 9 out of 10 people. It's about 91%. And the healing of dislocations is facilitated also with relaxation of tight muscles while the prolotherapy is happening, and Jenny's going to talk more about that shortly. So, the role of anatomy as it should be. Bones are our scaffolding. They are hard, they cannot bend much, and so they'll support us. Ligaments hold our bones together. Ligaments connect bone to bone. They should be firm and non-stretchy, like leather straps. Tendons hold our muscles onto bones. They should be firm at the connection to the bone and stretchy where they integrate with the muscle. And muscles are our movement. They are flexible and will stretch, and they should be like elastic. Thanks to my wife for this information. Ligaments in people with EDS are soft and like elastic, and they struggle to hold bones together. Our muscles then become the stability, and they attempt to take over the role of the ligaments, and they're tight, and they won't stretch when they should be able to stretch. And they keep holding that tightness until you lie down and they're allowed to relax. And they're acting like leather straps. And prolotherapy aims to help return the body more towards normal in combination with the other therapies that many of you provide. Just briefly, as mentioned, dextrose is a weak agent, still has some benefit. Ethanol aminolate is what we used to use as our first line. It's no longer available. We've got polydocanol and tetradecal, which are strong agents. A platelet-rich plasma appears to be effective as them, it's just more expensive. And sodium moroate we know about, but it has a higher risk for side effects, which is not so good in our people with mast cell activation. And so we don't use it at our clinic. Just briefly on a study, and this is an open source study, you can look it up free online. We had 46 patients, more than 100 joints dislocating between them, and it took an average of 3 injections to tighten up the joints. The range was 1 to 22. The mean was 3, the median was 2, the mode was 1. We'd had 2 recurrences at 3 years. One was in the lady who had 22 in her shoulder. It took 7 to restabilize it after she'd had a new injury because she had that much more tissue there already. The other was in a lady who'd had 3 in her hip. She fell downstairs. It took 1 to restabilize it. I can't stop new injuries. So in practice, we see that about 91% of patients respond well whether they have EDS or not. And that the laying down of scar tissue, building the tissue back to what it was prior to injury, stops the pain and gets people functioning normally again and stops dislocations. We've seen that there's major sustained results at 12 months. And we've seen that when the tissues are healed, we get relaxation of the tight muscles. But during the healing time, we are really relying on our physios and movement therapists to help those tissues relax. Taping can sometimes help. Sometimes we need to use bracing during that healing time. So we still need to provide people with pain relief during the healing time, but we've yet to have a patient not wean their opioids when their pain has gone. People don't stay on pain relief for the sake of it. But you have to treat all sources of pain to get rid of all the pain. Hippocrates noted one pain suppresses another. Of 2 pains occurring together, not in the same part of the body, the stronger weakens the other. He was absolutely right, way ahead of his time. That quote's from about 2,400 years ago. For example, if you've got a tennis elbow and you get that treated, but the pain's still there, we find that we have to treat the annular ligament, which is the radial sling, plus or minus the pronator or the supinator, and occasionally the radial collateral ligament. And if any one of those still has pain, then you've still got pain in your elbow, but you get rid of all the sources of pain, and the pain goes. And so when people still have pain present in the studies, it's because they haven't treated adjacent injuries. And sometimes the shoulder returns pain to the elbow. So if you treat all the sources of pain, the pain goes. And so if you think that it hasn't worked, look for the adjacent source of pain. Likewise, when we treat other areas of the body the same, and if you apply a force to a set of structures, it's hard to damage just one of them. You're going to damage more than one structure. And if you treat only one point and expect it to be pain-free, it's not going to work. You've got to treat all sources of pain. So what prolotherapy does not do, it does not do well with Achilles tendon because the Achilles tendon has a poor blood supply. It doesn't treat the deep visceral pains. It doesn't treat Chiari or other deep tissue anywhere where you can't reach a needle safely. There are some times where you do need steroids like carpal tunnel syndrome and Dupuytren's contractures. There are things like hydrodissection to help when you've got nerves caught up in tissue, and that was briefly touched by Tina as well. And we need our allied health to help during these healing times, and Jenny DeBon is going to come up very shortly and discuss all these issues. Help relax the tight muscles, tighten the relaxed muscles, and allow all these things to work together. Please give us questions and let us know at the end If I can't answer all the questions at once, I will answer them on Hoover afterwards. Thank you.